Good afternoon, everyone.
Okay.
Has everyone had lunch, their fourth cup of coffee, ready to learn about community health? Who in this room knows what a community health worker is?
All right.
Okay, this is an Aspen first. So we may dive in a little deeper than we might normally do here at the festival, just because we actually have a room full of a lot of people that know a lot about community health. Aspen's actually been doing a lot in community health with many of you who are here in the room. So I'm going to introduce these guys, and I just told our friends down here it's a very liability that I'm up here with these three because they're going to give me a hard time.
We're actually going to answer everything in the form of a question back to you. See how you do.
These are some of my most favorite people, but namely because when we think about community health, you know, I think it's apropos that we're in a tent. We really need a big tent to do community health well. It takes all kinds of approaches and traditions, not just these folks on the stage, many of you in the room, and many of you way out, far out, who are working right now in communities. And I can think of fewer people than these three who exemplify the spirit of community health, have really listened to patients, community health workers, and others. And so I'm just delighted to be on the stage with you three. So Raj, you are the CEO of Last Mile Health, a physician at the Brigham and Harvard. You and your wife, Amisha, founded Last Mile Health when you were 24 with your wedding money.
Yeah.
Raj fled Liberia when he was 9 as a child and went back at the age of 24 to start Last Mile Health. If there is an award for social entrepreneurship or health, Raj has won it, so we won't go into that. Likewise, Josh at the end there has also won countless social entrepreneurship awards. Josh is the founder of Medic Mobile. I think you started it while you were still in college. So these guys have this has been their life's work. Medic Mobile serves 20,000 community health workers with an open software platform that reaches 12 million patients. So really powerful stuff. And then Tendo is a management partner for AMP Health in Sierra Leone. They're already making fun of me.
No, not at all.
I told you.
I never would do that, Kate.
But Tendo comes from a little bit of a different perspective. He's worked in retail management at Amazon in Seattle. He's implemented a digital management system across Barclays all over Africa, has an MBA, has worked in 8 African countries, the UK, and other places. So he brings a bit of a different perspective, but currently is embedded in the Ministry of Health. Is Alpha here? Alpha. With Alpha, our friend Alpha over there, who runs the community health system for Sierra Leone. And Tendo's bringing that knowledge and that management leadership to partner with Alpha and others to figure out how we best scale these systems of excellence. So let's dive in. Raj, tell us, let's just get even though there are a lot of experts in the room, what, in your mind, what's a community health worker? Why does it matter for global health? Why is it critical?
Yeah. Well, I think it's critical because there's no way we're going to leave no one behind unless we have them involved. I think, everyone here would know, just by the hands raised, and many of you could be on this panel, and hopefully we'll get to have discussion. We're going to do Q&A as well. But you know that they are trained in several months to a year. They're coached by nurses, tied in with clinics, in the good programs at least. They're equipped usually with diagnostics that can be in the palm of your hand, therapeutics like pneumonia medicines, malaria medicines, and increasingly smartphones. And they are the ones who, where they're blazed, come door to door to find the sick, provide care to children, to families that need it, that may be either in an urban setting that has been excluded for whatever reason, can't access health care, or in really hard to reach remote rural areas, which is where we've worked a lot with our colleagues at the Liberian government. Right. But I think that the truest test of community health is a high quality program. And I think there's a big quality crisis right now in community health. Most countries can't tell you how competent a worker is, how many of their workers have the right supplies in place all the time, how many are getting paid on time, how many are getting supervised by those nurses. A lot of countries are struggling with that data, and that's just at the systems level. But at the community level, Community health workers have challenges sometimes in diagnosing illnesses or providing a proper referral pathway for, say, patients with a gunshot wound that may not have anything to do with what they're trained on. And so I think part of redefining community health in the future is making sure that it's quality community health. And a lot of people in this room are working on that issue. But we just came out of a meeting with Tom Frieden and Seth Berkley. I'm sure some of you were there. And Tom spoke so eloquently about the joint evaluation exercise for joint external evaluation, the JEE, which is a new way for countries to evaluate if they're ready for epidemics. They look at a number of performance indicators. We have nothing like that for community health systems that's agreed upon globally.
Why don't we?
Well, I think part of it's been the historical neglect of the workers. Until now, there's still majority are semi-compensated or volunteer. If you're not even paying a worker to do a job, you likely have not invested in the stuff they need, the systems they need, the spaces they need around them. I think that's the reason. I think there's hope on the other side of it. I think you can see high quality care. My colleague Ben Grant, Ben, raise your hand, who is a representation of that. Ben is a physician's assistant by training, and he's our program director at Last Mile Health. Ben thought very wisely when the government of Liberia wanted to put a community health worker program together and said, look, it can't just be community health workers, it's got to be nurses involved, physician assistants involved in coaching these workers. So Liberia went very dense with its system, putting nurses in a ratio of about 1 to 10, one nurse for every 10 community health workers. Well, why does that matter? It matters because someone like Ben and his colleagues can coach a community health worker like Serena, who's about 26 years old and has never previously treated a child for pneumonia or evaluated a gunshot wound in a community. And Ben went very far with colleagues there in a community called Bo, just to give an example, to square this, 100 years without any health care. They had volunteer workers, but they never had any additional investment. 2,000 people, forest community, 9 villages spread out across 34 miles in the forest. Very hard place to deliver medical care. Ben started by training a fellow nurse, a mid-level clinician, who then trained a dozen community health workers, paid them, supervised them, ensured they had the stock. Well, not only did they stop seeing child deaths in that community and got mothers into care where they had been 20 hours away from the nearest hospital, but the community then said, look, this is not enough. We are going to build a community health clinic. And they worked together with Ben and the team, and why wouldn't they want to? There were adults with high blood pressure problems and heart failure. There were people with gunshot wounds who didn't have an initial place to get care. And they were able to, after 100 years after the system had failed them, to work together with the public sector, with community health workers, because there was a nurse involved who could show how far healthcare could go. And they built this first community health center that saw, in its first days, about 480 patients just in the first week, and it's continuing 100 years, right? And there's plenty of places that have gone centuries or close to it without any healthcare. So until we're willing to invest in supporting these workers, which sometimes involves supporting workers around them, right, I don't think we'll get to a place with quality.
Right, and solve the quality crisis.
Right.
Josh, I'd love for you to jump in here because likewise, you've trained community health workers in a little bit of a different way and have thought about how to layer in quality metrics and quality training. And it can feel really abstract when I hear about Medic Mobile and your software. I'm wondering if you can just train us for one moment in this room.
Totally.
And give us some grounding. I mean, that was helpful grounding from Raj, but from your perspective, you've been doing this a long time. Ground us a little and maybe train us just a little using what you use with community health workers all over the world.
I will be happy to, but I got to go off script for one
Great.
second. Raj and Ben and everyone in this room, thank you for your imagination and your leadership and your commitment. What you are accomplishing is amazing. I'm also amazed by what the community health workers accomplish every day. And I wanted to just share a potentially controversial comment, or just to try to put this in context a little bit, following up from the CVS and Kaiser panel yesterday. That the 20,000 health workers we have the privilege of supporting just with a sliver of support, with tools. they're covering 12 million people and doing everything in their power every single day to care for their neighbors. That happens to be the same membership as Kaiser. Numbers, 12 million members. Kaiser's annual operating revenue is just over 70 billion, 220,000 employees. So that signals to me one thing, and complement that with US spending of $10,000 per person per year, and really forcing people in this room to justify spending $10 per person per year. It's not just unjust, but it's just irrational. So a global economic system and people participating in that, judging the per capita spending by our ministry colleagues here, it's got to stop. We've got to look at this again. So I had to share that, that we're just not doing nearly enough. Mel, I'll do an app demo.
Man of many talents.
Some people may not know this, but Josh has built, that sense of equity is truly a part of who you are, Josh, and you have managed to weave that through training and weave that through your work, including a software app. You've put an equity lens on it, and you've pushed many others to join you in that. People probably aren't joining fast enough, but thank you for always pushing that.
Thanks, Katie. Well, I'll do this in 30 seconds. And for the record, it's a bad idea to train community health workers in 30 seconds. But we're gonna give it a shot anyway.
Don't go treat anyone coming out of this tent.
Yeah, we could talk about that later. But let's imagine that we've signed up to provide care for our neighbors, that we want to be of service in our community. Ideally, we're getting trained on the components that Raj was just walking through as we're getting trained on the tools we'll be using as a caregiver. In our training session, we're going to be with neighbors and with ourselves going through what it's going to be like as a community health worker. One of my first responsibilities is going to be to go door to door and create profiles for every family and every person in every family. So I've got my list of families here. I'll go into Chelsea's family, see some basic information. We'll see how Chelsea's doing, and then come back out and actually go to a different family, Deanna's family, see how Deanna's doing, and come back out. But most of my work is going to be not about households. I might get guided through hanging a bed net or something else I'll do at the household level. Most of my care is going to be provided for people. So let's say that one day Daisy is sick. I'll pull up Daisy's profile, and then I'll be guided through an action. And this is a very small point, but I think maybe an important one. We think about all of these workflows as things that people are doing for one another, and opportunities to provide support for that family and for that health worker, not as a form that's completed, which is surprisingly a very big change in global health. But I'm going to get walked through an assessment here, relatively simple. Let's say in this case, I have a child with diarrhea. It's just been a few days, but there's some bleeding. No other danger signs. In this case, and it's really interesting here, this results screen gets turned around in the home visit the majority of the time. And the community health worker, the family member, and the head of the household are typically looking at it together to decide what to do next. So I'll get guidance on treatment. And in this case, I need to refer to the facility. So as soon as I go through this action, the nurse at the facility is going to get a prompt and see on that same profile who's coming to them. So that's nice. And then as a community health worker, I'll then wake up every day and look at my task list and look at which families need my support based on how the system's been designed. And then I'll look at a dashboard that shows how I'm doing compared to goals that I've set for myself and with my community, with my managers, and all of that runs offline. End of demo. Go back.
It's always ironic to me that you run a software platform because you literally hate talking about the technology, just like you were like, I don't want to look at that. But I think part of it is it's too easy to be reductive and sort of look at inputs and outputs. And I wanted to quote, there's a community health worker that you work closely with, Consolata Juma, yeah, who we met recently. And she said, I just want to read something that she said. She's not here with us, but I wanted to bring her voice into the room. She said, the most important thing I offer my patient comes from my heart. when I come to care for my patients when they are ill, they know that they belong, they know they are not alone, that another human cares about them. And so it's not just about scaling technology, it's about scaling sort of the ethics of care. And who in here in this room has met a community health worker? I have, okay, so like, again, this is like, are we in Aspen? Where are we? But well, we're all here in this tent in Aspen. But I think what's interesting is I've never met a community health worker that has reduced it to sort of inputs and outputs and processes. While they respect those things, it's always about the patient and the care. And to your point, Josh, and Tendo, I'm coming to you in a minute, but Josh, to your point about how we globally think about our economic systems, how do we scale that sense of care? How do we not, when I hear a lot of folks who work at Scale Talk, it is about scaling inputs and outputs and outcomes. How do you also scale that essence of care that Consolata refers to?
I'm going to channel some wisdom, and I think each of us should just quote others in the room for the rest of the panel. But I'll channel some wisdom from, I'm staring at Ari Johnson from Muso, who talks about community health workers and CHW-led systems and the autonomy that community health worker needs to be treated as a CEO on the front lines, who knows their community and their patients best. And it's those types of principles that we just need to hold as big systems are designed. So I think it's those nuggets of wisdom we need to carry.
Well, and just to add on that, I think many of us have seen this, but you're struck no matter how many times you visit a community health worker or any caregiver by being closer to suffering, by being closer to alleviation of suffering, how inspiring that can be. And I think we have seen policymakers completely shift the way they invest in these workers and therefore invest in primary care at least in Liberia, rural, remote communities by visiting them. I'm just reminded by Ben and my colleagues, some of you have worked with Dr. Bernice Don, who was the most recent former Minister of Health. Extremely, no way would have West Africa or Liberia at least been able to respond to the Ebola epidemic if it wasn't for Dr. Don's leadership. And she was very much of the mindset, how could you not be, when you see 60% of your entire population, of your rural population being an hour or more from the clinic, having no physical access to care. That was a situation that she found in 2011 when they did their national health plan. So she had always been interested in solving that problem, but part of it meant being shifting not only the values for her to be more connected, but of her team. Right. So she actually came out to Bo. She got lost in a helicopter on the way out there. This is a story for another day. We didn't deliberately lose it, I promise. But she ended up making it, and she saw a community health worker that was part of a demonstration project that she herself had sanctioned that said we were going to move from volunteer, unsupervised, or just peer supervised workers that were not well supported or with the stuff they need to provide care to one that was actually in the right system, that was paid, that was clinically supervised, and with her own eyes saw that this worker was able to do some of the things that she was able to do. Not everything. Community health workers are not a panacea, but she was able to see that being effectively delivered, and her team was with her. So they then took that back, started to move forward, and then, of course, when you have something like Ebola that brings you extremely close to that kind of extreme suffering, you see these workers go door to door to find the sick, get them into care with nurses and doctors. You can't help but be moved. So I think a lot of the work that we need to do, as you know, many are friends with Brian Stevenson, has seen so much of his work from Equal Justice Initiative. But I do think the work of proximity in healthcare, community health workers bring us to that. Caregivers
you
who
inviting everyone to Liberia?
I am, yeah. We will hire a very big helicopter. No, we'll probably hike, as we did with James over here for 2 hours in the forest.
So let's, on that, let's go to Sierra Leone. Tendo, to you, also struck by Ebola. Sierra Leone was struck by Ebola in 2014. Your background's in business. Your background's not in health. I want to know why you came to this at this moment in your career where you could have been like, I don't know, CEO of some big company, but also how you bring your business background to this. I mean, we're working in this public-private partnership. You're embedded in the Ministry of Health in Sierra Leone. What's sort of the opportunity you see right now? Where do you think there's some movement where you want to put your background and energy?
Sure. To help answer that, I'm going to borrow from the first session from yesterday, the one with Larry from CVS and Bernard from Kaiser Permanente. And I think one of the things that Bernard brought
I think
up
we should
was
set up a meeting with them.
was this idea of coverage and care, coverage versus care. And I'm going to try to use that to walk you through my thinking. I think it's important to understand community health systems, at least from my point of view, and to help me answer your question. So I think of community health systems in 3 layers. The first layer being sort of training, so identifying the community health workers, training them and providing them with the skills to do the job, right? So that in my mind, of course, community health usually is at the last mile, but ideally you have nationwide coverage. In my mind, that resonates with the coverage part of the coverage versus care idea, right? Then moving on, the second layer would be, once you have these people trained and have the skills and tools, then they need to be supervised, right? They need to supervise in order to ensure that they give the right kind of care, right? And supervision, I think there's the Community Health Coalition convened by Madeline over there, and I think your organization...
It's called CHIC.
Oh.
Community Health.
Impact Coalition, yes,
Doesn't
CHIC.
leave this time.
Don't forget the I.
Yeah, and Last Mile Health is a part of that coalition. I think they did a study across successful community health programs and identified supervision as being one of the key things to success of the program. So supervision that enforces quality of care, I think in my mind relates to the care in the coverage versus care. Now, for the third layer, I think once you have people trained, they have the skills, they supervise, they're providing the care, then you need data and results, right? Information, and this is where Josh comes in, right? So we need to use the data, first of all, to assess the outcomes of what you're doing. So people are trained, they're doing their job, but what does that mean in reality? You know, are people getting better? What is the outcome of that coverage and care? And that's why I like to extend that idea of coverage and care to coverage, care, and outcomes, right? And I know Josh's organization has been doing a lot on the data side, as he showed you earlier. So that's my thinking. Now, when you think of community health that way, the question then becomes, how do we do that? How do we pull that off, right? Who's best placed to pull that off? In Sierra Leone, where I work today, we have a history of fragmentation. We have organizations going all over the place in their little corner of Sierra Leone, doing their own little thing, and that sort of violates the coverage principle in my framework, right? Coverage is ideally universal. You have the same service delivered to everyone. If you were at Dr. Agnes' session before lunch, there was this idea of inclusiveness that was highlighted there. So you cannot leave out anyone. So clearly, NGOs fragmented in the country don't tick that box. So move on to the next layer, care. So usually an NGO doing their own thing in a little corner of the country usually has a certain list of indicators that they want to tick, right? That's usually informed by wherever they get the money from and things like that. For a nation, you cannot afford to do things like that, right? In addition to inclusiveness, you need comprehensiveness, right? You're not only treating malaria, HIV, TB, etc. You want healthy people, whatever the issue is, right? So that also violates the second layer, the care layer. Of course, coverage and care drives the outcomes, right? So the question then is, who is best placed to do this sort of thing? And I'll pose that to the audience. Who do you think is best placed in any country, Sierra Leone, for example, to run this sort of framework for community health? The government, right? So that's...
Did you plant those?
No, no.
All sitting together.
So this now, speaking more broadly towards your question, so the government, is ideally best placed to do these sorts of things, but of course, on the flip side, the government usually has capacity constraints, resource constraints, and organizations like Last Mile Health, which I know in Liberia to sort of enable them to do their job, right? The other side of that is capacity. And that's where organizations like AMP Health come in, and people like myself. We know that we have private organizations all over the world that do this thing on a day-to-day. Kaiser Permanente, CVS Health, they do these things with, 220,000 employees or whatever. We have 15,000 in Sierra Leone, right? So why not borrow from that expertise, that basket of expertise, to lend a helping hand, to the government? And that's where people like me, from investment banking or wherever, try to leverage our skill set to foster better delivery in the government.
I think some of what you're painting is a picture of the future a little bit, sort of like how this might evolve. I want to open it up to the audience, but if you could just give me a sense, paint a little picture briefly, because I know we could like go sit for hours and talk about this, but just briefly a picture of the future. Like what would it look like? I think we have made so much progress, but you are three of the most imaginative people I know, but also incredibly determined. Just give the audience a little bit of a sense of what we should be looking towards, and then I'm coming out to all of you.
I mean, I think maybe the best way I can do that is, I'll cite two things. One is, I'll talk about just a patient that we cared for, Ben and colleagues in Bow. Someone we actually, that suffered a very poor outcome. It was a 70-year-old man who lived, I'll just call him Albert. He lived next to a community health worker in one of the villages in Bow. And after his neighbor got trained to provide medical care, she noticed that he was breathing really hard one day. She got the nurse to come in from the clinic. He evaluated her, Emmanuel, who Ben will know, and one of the nurses that had gone there to train that Ben initially had recruited. And blood pressure cuff on, listened to his lungs, and I was there with him. Florid heart failure, meaning his heart stopped working. He had undiagnosed hypertension, high blood pressure for probably 10 or more years, and his heart was racing, and he had that look of someone that looked like they were suffocating, drowning in their own fluid in their own lungs. And in the U.S. or in Monrovia, what we would have been able to do for him is to get him started on something to control the heart rate, to make sure his blood pressure comes under control, make sure he can get the fluid off with medications, make sure he's being monitored closely, his vital signs are being monitored closely. We started him on some of those medications, and then eventually the rainy season came and supply chain got interrupted, and he ran out of the drugs. We ran out of drugs to get it to him, and Albert lost his life about 6 months into, even after we knew he was there trying to care for him. So I think the future looks like partly what Bo did, which is to build a regular community health center there that can be stocked with drugs all the time. But the future also would look like a community health worker who was equipped with, either has been trained to do blood pressure, or if that's not possible, which it should be, because if a community health worker can dose an antibiotic and you and I can get our blood pressure checked at CVS, community health workers can probably do a blood pressure, right? It'd be the logic behind it. But they should have a smartphone that allows them to actually monitor consistently through peripherals, which are already available, right? There's a new peripheral that allows you to do ultrasonography of every organ in the body for looking at babies or looking at the heart. That should be available at that patient site. When the drugs were needed, we should be able to get Keller in here. I don't know if Keller from Zipline's here, or his team, to get a drone to bring the drugs when in such a remote community, and so that he started on it. The lab samples for monitoring should be taken back to that clinic. Right. Now, that might sound hokey to some people here, maybe not to this room, but it's not actually hard to imagine the future, because the future is already here in some places. In Alaska, they have been for the last 20 years being able to provide care for patients just like Albert in the most remote parts of the tundra, because they have invested in technology systems. They've shifted tasks to community health workers and mid-level providers that otherwise would be reserved for specialists and physicians. Of course, physicians are still involved in backup through telemonitoring, and they've actually designed stuff that is palm-sized or works in off-grid, off-road, off-network settings. And they've used spaces that aren't necessarily power plant-like spaces in hospitals, but more like a microgrid approach. They've started to do care in the home or in community-built health posts that are of high quality. So they already have that there, and they were able to add dentistry care to their work, and they were sued by the American Dental Association for adding dentistry care. A community health worker program of Alaska was sued by the American Dental Association because they argued that they shouldn't be able to do it, to be unsafe care. And actually, when they used the science to prove it, that in fact it was safe, they were being telemonitored by dentists remotely, the Alaskans presented those findings in the court case and also said, by the way, there have been 40 vacancies for 40 years for dentists. No one's ever come to fill them. So when we get sued, is the moral of the story, or get challenged, then we know we're going far enough in terms of imagining what care can be delivered. And we're just not even imagining it at all yet. I mean, some countries have, but not enough of them.
So making some trouble. Okay, Tendo, to you.
What Raj said, basically.
What Raj said.
I'm going to steal Josh's mantle and try to focus on the digital part, the information technology part of what Raj said. I think there's a lot of potential technology has got to a point where it's now cheap enough and scalable enough to be deployed sort of across countries like Sierra Leone. 15,000 seems like a big number to have in terms of a community health worker workforce, but 15,000 handsets is nothing, right?
Right.
And you can do a lot with these devices. You can, as Josh showed you, register people, keep track of them, have the reminders. It takes almost the thinking out of the job. Not that that's not important, but it makes it easier, right? So I think that's part of the vision that I see for the future, using technology to leverage, to tackle mostly the coverage and care buckets in my framework, right? And I think we can go a long way with that.
Josh.
I think what I would dream for this tent is, put it crudely, 1,000x. So I think all of us going from millions to billions would be beautiful. I think that looking at Matt Bond's, and we've mapped out 1,000x cube last week, I think, where we sort of imagined 10x in a couple dimensions. You imagine 10x in what community health workers can do, and last mile, MUSO, PIH, Integrate Health, they've proven it. It can be done. It can be done with 8 simple principles deployed at scale. So that being normal everywhere, those outlier results being normal everywhere is one of those axes, is one of those dimensions. A 10x in scale, working alongside our ministry partners here who are leading really visionary strategic plans to redesign and support their national health systems, has to be the path forward. And maybe there are other dimensions too. Maybe it becomes 10 times easier to become a health worker, right? And maybe we have a proliferation and a continual revisiting of who we define as and treat as a health worker, and support as a health worker, and connect to a system as a health worker. But that together gets us to 1,000x and gets us to billions.
Wow. I told you they had big imaginations. Okay, out to you in the audience. There's a microphone going around. Raise your hand if you have a question. Dylan? Oh, that guy right there.
Yeah, thanks you all. I'm Dylan from AMP Health. You've all spoken about the use of technology with community health workers in getting care to the front lines. I'm interested in hearing from you about how technology can work in the other direction and taking those frontline stories back to a national level and to inform policy.
You said to the what level?
To a national level,
Yeah.
to a policy-making
Yeah.
level. I'm working in Zambia at the moment, and we're having conversations about how we include patient voices and community healthcare voices in the formulation of policy. And it seems like the areas you guys are working on, except Tendo, that could really help inform policy and drive policy that's more patient-centric.
Yeah, I'm happy to offer a thought. Madeline, who's sitting right next to you, actually was part of the learning for our team with the Liberian government. She and others, when the ministry found this gap, I think the first point is, number one is ultimate respect for the countries that lead this work. And ultimate respect is not, I'm here to do TA to assist you. It's not, I'm here to build your capacity. It's here, you give me marching orders, and I will work with you to figure out if we can solve a problem together. And that sounds like a high philosophical thing to say. There's actually tactics that go along with that are different. So we were schooled by our friends at CHI, the Clinton Health Access Initiative, who's done this work for a very long time. I know Cassia Holstein, who had worked with them before working at PIH, had put us in touch. They said, when you go to a minister and you want to figure out a more patient-centered approach or an innovative way to innovate on a policy, in our case, it was paying the workers, supervising them with nurses, et cetera, as I described earlier. You ask them, what are your questions, your policy questions, that we might help you answer in a demonstration project that we could do together? Which is a very uncomfortable thing, actually, for social entrepreneurs to do, because you come in with a plan and a model and everything else, and if If you're lucky enough, as we were, to have a lot of failures early on, to learn that it's not a model we have, but our model is actually working with the government to design and demonstrate with a new way to and help them scale a new way of delivering this care, then you get a real answer. And the answer was, actually, that's where we came up with those ideas. Pay a nurse supervisor. It was Dr. Don and her team that told us. So I think that's a big part of it, that is both being clear on the philosophical approach, but also translating that into tactics like that one. And what that ultimately did, it wasn't that Dr. Don got on a helicopter one day because she just on a whim wanted to take a joyride into the forest. It was because she had been involved 3 years prior in the design of the project, and she wanted to finally had a chance to come and see it. And so when she saw patient-centered care being given and hearing from the communities, as Ben and I have heard, and Madeline has, that where children used to die, they don't, where mothers used to get hoisted on hammocks with branches that are made of lapa cloth only to try to get to the hospital and perish before they get there in obstructed labor or hemorrhage, you can't help but be moved by wanting to do more or something about it. But it starts with that ultimate humility, which again is uncomfortable, I think, for a lot of us who get schooled in, here's your model.
Yeah, thanks, Dylan. Just to try to answer briefly.
I'm really bad at that. So.
No, I feel your
We
pain.
forgive you.
I think that a citizen insight system should be fully integrated with any service delivery and performance management system. Sounds really wonky, but I would love to talk through the details of that. I think technology has a clear role to play. I think that we're going to see more conversational interfaces with patients that then integrate with doorstep care.
Yeah.
I think there are some really great examples of CHW-led digital storytelling that have influenced policy with mobile tools. And to go to the data for a second, I think it's high time for an equity lens to be just part of the monitoring and management systems. And I think it's super practical to do that now, where it hasn't been in the past, to see not every 5 years, not with a retrospective survey, and not nationally, but every month, at 10,000 families or less, how is that system performing for subpopulations? And actually, let's take those results to the community. Let's unpack the stories, and then let's co-design solutions, go back to the policymakers and say, for us to achieve equity, this is what we have to change. So I think data should be really powerful.
Okay. Here. In the front here in the white shirt.
Some parts of our country, especially in the Deep South, look like some of the countries you've described here. So could you talk about community health workers as a solution here and also what the state of it is?
Thanks for that question. Who wants to take it first? You want to say something, Tendo?
I can try. I mean, I'm not from here.
You want to school us?
No, but I think just to echo some of the things, again, I think Josh advised that we should quote each other. So I'm just going to quote Dr. Agnes from the session earlier. I think the main idea was that you cannot really separate health and sort of other social factors. They're not two independent things, right? It's one and the same. So I think the biggest issue here that I've seen, and again, I'm not American, is that there's a tendency to sort of delineate. In Sierra Leone, for example, we have this what we call vertical programs, where implementers come in and do their little thing vertically. The ideal solution is comprehensive, right? Inclusive and comprehensive. So to the extent that you move away from looking at health as some independent entity of the well-being of the country or the economic growth of the country, I think the more progress you make toward improving the health outcomes here.
Anything specific? I mean, you brought up Alaska, but and you both live in the U.S. currently, mostly.
Yeah. I mean, I'll be brief here.
Oh, really?
I think people should go to Alaska. I really do. Anyone working on rural healthcare in this country should at least go and see them. And they've had people come for many years. The Rasmussen Foundation takes study visits up there. And anyone who wants to, who works on this, I'm happy to put you in touch. But I think what they've done in remote, at least in very remote rural healthcare, can be very much a model that can be adapted across rural parts. I resettled after I fled Liberia in North Carolina, and there are rural parts of our state that could use more of the kind of model they have.
I don't know the diagnosis, but I'm amazed that more bigger things aren't being tried. In that, and I'm really sorry to be so harsh on the CEOs from yesterday, but there was a question about talent. And they went immediately to engineers and business school grads and their competition with Google and Facebook, when there are millions of Americans looking for meaningful work in their communities. It's just an obvious answer.
Naomi.
I'm Naomi from Liberia. So, Joe, you don't have to carry everybody. I'll go along with you. Yeah, I just left a section that says, who is prepared for the next epidemic? And I'm here, and I'm saying community health worker, the line of the first defense. I said it to say that I was one of the first responders during the Ebola outbreak in Liberia, and I saw firsthand how community health worker, there wasn't even health worker, but women took the front line and decided to respond to the outbreak. They wasn't trained, there was mothers, there was sisters, but they were there. And because they wasn't trained, we see that there was an increase in the death rate and the infection rate was so high. I said that to say that the work that My Health is doing in Liberia, it's so brilliant. It's so good because it speaks to localization. It speaks to an expert going into a community and training the locals that are at the front line of the response of any outbreak or a disease. So last My Health, my question to you, what is in your plan to scale the work that you are doing? Because I know you are only in the Southeast, I've been there, I've worked with most of the women you work with, I'm a nurse, I have my master in public health, your work is so good. But what is your intent to scale out into other parts of rural Liberia that is desperately in need of the services that you are providing?
Well, thank you for what you did, first of all. I just think that, and thanks for sharing that. Actually, a lot of what you did had to do with what's happening now. So it's nice for you to give us credit, but the credit goes to the Ministry of Health and all the partners, International Rescue Committee, Plan, Partners in Health, and importantly, the communities themselves who are teaming up with the government. So after Ebola, they had the same question. How do we scale this? Because there were some 10,000 community members who went door to door, as you know, to help find sick patients, get them into care, and help hunt down the virus and stop it in its tracks. And President Sirleaf, and now President Weah has continued this, has made a very strong, bold commitment to hire up a national community health assistant program, which has now trained, hired, and equipped 3,000 community health assistants covering about 70% of the country and about 300 nurses to support them. So they're there, and just to tie it into the epidemics, importantly, Liberia is pushing for quality. They're not there yet, but they're pushing, and they know, I was just looking at a report on epidemics. What does this have to do with Ebola? They went from 20% of infectious disease cases being reported, only 20% within the first 48 hours. It's one of the JEE metrics, the performance metrics, to 82% of that being reported within 24 hours. While this scale-up was happening, 20% of all infectious diseases in the country are now being identified by these community health assistants, and they've helped respond to measles, meningitis, pertussis, Lassa fever, along with teams of other professionals. But without them being the eyes, the ears, and providing the follow-up care and support, you wouldn't have it. So there's a lot more work to do, and we'd love to, ensure that program links up with what you're doing in Liberia.
Other questions? Severe. And I want to get, we only have 5 minutes left. I want to get about 3 more questions, so let's do a little bit of rapid fire.
Thank you so much, Josh and Raj, and you're doing awesome work. But my question is about community which doesn't fall in normal settlements, and mostly they're nomadics or gypsies. Like my community I'm working with in Lahore in Pakistan, where do I come from? And mostly they can't even get basic injections and immunization, and mostly because they have a lifestyle. And when we try to approach local doctors, and they ask us, why don't they settle over here? But that's not our lifestyle. We're gypsy, we keep on roaming, and that's our lifestyle. But still we want to access health, because that's our human right. And most of us, we can't assess it. And I don't know, even I'm looking at your software, I don't know, how can we tap it? And we struggle a lot about that.
Yeah.
Right, so with nomadic
Do you want to
community,
take 2
yeah, let's
other
take
ones?
a couple.
Let's
So with
do it.
nomadic
Thank you.
communities and even other, migrant communities that are sort of on the move, who serves
Yeah.
them? Back there, you've had your hand up for a while. I want to make sure I get you. I'm going to take her, and then one more, so Garrett will get you.
My name is Josephine. I work in policy in DC for Caring Across Generations, but I'm from Malawi. And my question is, can you talk a little bit about the sustainable business model side of things that allows you to finance sustainably and continuously things like worker compensation and continue to sort of invest in models like this?
Great. And then right here in the white shirt. And then we're coming back up here.
Yeah.
Yeah, Gary Cohn from Healthcare Without Harm. The question is, where's the multilateral organizations in funding this? I know in the past, they wouldn't get funding for community health workers, so
Right.
couldn't scale it. So where's Gates, where's World Bank, et cetera? Builds on her question.
I can probably take the last one if
Okay. Tendo, you want to kick us off?
Yeah, I'll take the easy one.
Okay.
I think one of the key building principles of any community health program, and this we have in our policy in Sierra Leone, fortunately, is that the community health workers need to be part and parcel of the community, ideally, right? So, like in our policy, I think the community itself selects the community health worker, and if they have the requisite skills, well and good. If they don't, we do some top-up training to bring them up to speed. So in your case, where the community moves from place to place, if the health worker is part of the community, that's not really a problem, right? So ideally, that's what you want. And there's other fringe benefits of having the community health worker being part and parcel of the community. Number one, he or she knows everyone in the community, right? So things that someone who's coming from elsewhere might not be able to pick up, they're already privy to. So I think that's the approach that's being taken, and I think SHIC, that's one of your guiding principles as well.
Yeah. Josh.
Mohammed, thank you for asking. The day after the last U.S. presidential election, I was in Kakuma on the border with South Sudan and Kenya, working at the camp and understanding their health system, but also working with the Turkana community there. And I just would say flat out, we have failed to serve and support nomadic populations. And that is a really scary example because of climate change and other factors, we're going to see hundreds of millions of people on the move. And we're going to fail them too. The health systems are going to fail them. So I think there's an urgent need to redesign systems, probably again, from the social networks up. Sort of decoupling system design from the current built infrastructure and just being way more imaginative. And to your point about how technology evolves, this I think is a role for philanthropy. And it's not a popular thing to say, but I think it's very clear to me that in order for technologies to evolve in a very specific way to solve problems for the communities you're serving, philanthropy will need to step up.
Yeah. And Gary, to your question, the truth is that the multilaterals and bilaterals have been paying for community health programs for a long time. I think they're frustrated in many cases, like many of us on the provider side are, with not getting the results from that investment. There's a wonderful report that Madeline and Ari and a number of folks have worked on in this room at Community Health, chwimpact.org, that talks about the 8 principles that are needed to upgrade, to professionalize and optimize community health systems. It costs money to pay a worker $70 to $100 a month. It costs money to hire a nurse to coach them. It costs. So actually what we're seeing now, thankfully, is some real leadership from the Global Fund, the Global Financing Facility, Gavi, USAID, to try to invest in those areas. And the World Health Organization will be coming out with its new guidelines this summer, which we think will reflect a lot of the things that need to change. But there's still a $2 billion gap just for Africa alone. Our friends at Financing Alliance for Health and USAID, Dave Milestone here, had figured that out with a number of countries in Africa. That's just Africa alone, a $2 billion gap. So we need a lot more. Although there's been great attention, I don't think we should make the mistake that we're anywhere close yet to where we need to be and can be.
Mm-hmm.
Katie, I'd like to pass on my final comments because I know we're at the end here and ask you a question instead.
Oh, I told you we were coming back. We've all prepped this together.
You really do sit in a unique role and in a unique position at Aspen and within the Innovators Group. Mm-hmm. What did we miss in this conversation, and what are we missing in the conversation generally?
Yeah. And I think it's a good question for all of us to be thinking about, to be honest, because it just feels to me like you say a $2 billion gap, more workers to be trained, more people wanting meaningful work. I think it's going to take a lot of us to help figure out what that is. My hope, you know, in this role we play at Aspen is that we can help make this tent bigger and hold some of these ideas together. You all have so much expertise that goes so deep, and it can be hard to link across. I commend many of the people in this room for the work they've already done to collaborate, but I think there's a lot more work to do. Collaboration's really hard, and part of the magic of community health is that it's really relevant to a community. And so I think that is hard to then think about, what does that mean at the worldwide level? You know, what is true across communities? I mean, you have these 8 principles. That's a start, right? That's a piece of it, but there's more. And I would like to see, I mean, so encouraged that WHO is coming out with guidelines. To Gary's question, like, I think funding has to step up dramatically. And I think in a more coordinated fashion. You know, most cadres of health workers have like an association of, I think we have many of them here, hospital associations, doctors associations, nurses. We don't have that for community health. If you are brand new to community health, who do you go ask? You probably go ask one of these guys, but you're busy working, right? So who are some of the organizing bodies? And I hope that Aspen and many of the people in this room can continue to help sort of collaborate and coordinate and make this tent bigger. Yeah, that's what I would say. So thank you, Josh, for passing the mic. And we're well over time, so thank you. But I will just want to say there are so many experts in this room. So you saw who raised their hand. Find each other later. Certainly these 3, but there's a lot of wisdom just right here in this tent and elsewhere on campus. So thank you 3 so much.